When Shana was talking about what she would like to see from research, one of the things that she mentioned was speech. And we now have Professor Anya Lowett from Strathclyde University in Scotland to come and talk about some of the work that she's been doing on speech. Very fortunately, from our point of view at ATAXIA UK, a lot of it with us, but we thank her for everything that she has done, and we look forward to hearing her presentation.
Thanks very much, Sue, for that lovely introduction. And like everybody else, I'd like to thank the organisers and the sponsors to bringing me here to be able to talk to you in this fantastic location. So let me just see if I can get my presentation up and running. Double click. It's up here again. There we are. Oh, you're doing it for me. Perfect. Thank you. I was wondering why I had disappeared. I do have to apologize in advance. Well, I picked up a bad cold on the flight yesterday, so I hope I get through this without too much coughing. We've lost my presentation again. I'll just wait until it's back up. Okay, is it all running now? Lovely, because I can't see it on this screen. It's on that screen. Yeah, I'm going to have to click a video at some point, so I need to be able to see it on here. Right, okay, I think we're up and running. Let's get this. So, session about speech therapy. I'm sort of three things I want to impart to you today. One is going to just talk about what is communication, how does it present in ataxia, give you a research update of all the great work that's been happening, fortunately, over the last few years, and then hopefully leave with you with a few takeaway messages. So let's see if this works. Yes. Okay, so let's just talk about communication. What determines successful communication? Because the very overt thing that we observe with communication is speech. And so that's immediately what everybody thinks about communication is. So when we speech, we're talking about having the right, enough breath to produce the sound, being able to produce the sound in our voice box, and then being able to say the sounds that make up the words and sentences that we want to get across. But my profession is not called speech and language therapy for nothing, because there's lots of other things that are happening behind, that are going on in the brain before we even start saying the sounds, and that's what we term as language. So we need to be able to find the words that we want to express, we need to put them together into a grammatical sentence, we need to be able to have a conversation with people, come in at the right point in, in a conversational exchange, lots of things like this. And language, as Professor Hadjivassiliou has told us this morning, is quite closely related to cognition, and cognition can also be affected by cerebellar degeneration. So it's not as common as speech problems, but it's something to keep an eye out for. And then there's all these sort of other factors around it that are not directly linked to speech and language, but again, that are very important for successful communication. And that is, as we've just heard, fatigue. It's effortful to speak when you have ataxia. So if you're tired anyway, sometimes people say, no, I just can't be bothered to speak. That's what our patients tell us, it's too much effort. Again, something connected to cognition, attention. If you're following a conversation, you're trying to get in at the right point, you have to attend, and again, fatigue and cognitive problems can affect that. Confidence, a very, very important aspect. If you're not confident about yourself, about your speech, it's difficult to communicate with others. And then the speaking environment can have an impact, as well as who your communication partners are. Is it very formal? Is it more relaxed? And how are the people conversing with you? How understanding are they? Is it noisy or not, etc. And so do you actually get the opportunity to contribute there? What do we actually know about the challenges that people with ataxia experience? Now, ATAXIA UK ran a survey of their members a few years ago, and we kind of published the summaries of it. And one of the questions was, what's the frequency of symptoms? And they're kind of in order of sequence here, what's the most frequent? And we always find balance, walking, is a kind of top symptom, but we can say that slurred speech was sort of symptom number 5 in terms of frequency. And the other thing I just want to mention here, and it's not related to speech, but it's something speech-language therapists look at, is swallowing. And as we just heard from Shana, that is actually quite important as well, as, how people are able to eat, not just in terms of getting nutrition into themselves, but getting in a sort of a very personal thing, because, eating is a very social activity, and if you can't take part in that, it can have quite a big impact on your life as well. But I will focus mostly on speech today. It has a big impact, so when we're again looking at how did the symptoms impact on your life, what were your top 3 symptoms that impact, we do find communicating with other people, again, being one of the sort of top 3 symptoms there, and so it is affecting people's lives. And although the survey didn't immediately ask, what are the actual consequences of these communication problems, when we looked at sort of wider challenges, you can see how some of them are related to poor communication, like people avoiding social situations, having a lack of confidence, self-esteem, feeling isolated because they can't communicate with people anymore, and having to give up work or not being able to enter the workplace because of your communication problems. So it's definitely something that affects people that we need to treat if we can. So how can speech-language therapy help? Well, if you look at the literature, until 5 years ago, there was no study on progressive ataxia at all in terms of clinical trials, people trying to devise therapy. And therefore, the therapists are really unclear about how to support people effectively, because it's a rare disorder. Your general speech language therapist will not have seen someone else with ataxia. There's no literature that they can read up on. And so what happened a lot is that people were sort of giving some general advice maybe, or sort of a short, 6 sessions, and then weren't seen again, and we were kind of missing that sort of longer-term follow-up, providing support at different stages. Another problem is that quite often we say it's best to come early on in the disease progress, because that's the best place to learn strategies, etc. But again, because people didn't have an understanding how quickly things progress, they weren't being seen at the right time. So as I said, since 2018, we do have a number of publications, and they're all small studies, because before we kind of do big, large-scale trials, we obviously need to find what might work, what doesn't. So I'm just going to sort of very briefly run through some of the studies that have been published. And they're kind of... The things that we want to look at is, who did they treat, obviously, but also how did they measure speech, because we kind of have the sort of underlying basis for speaking, like the breath and the voice, etc. How can you say individual sounds? We then have something called intelligibility, so how understandable are you to others? And then there's a sort of very big area of communication participation. You actually use your speech to communicate with others and take part in social life. And so there's one study here that was done with patients with MSA of the ataxic type. It's a speak-out program, so it's sort of based on Parkinson's therapy, looking at speaking loud. And they found some improvements in sort of underlying areas of speech and some intelligibility improvements. They didn't measure communication participation, and that's a theme that you're going to see running through a lot of the studies, but at least they found some improvements there. It's an intensive program. It's 16 sessions over 4 weeks, so 4 sessions a week. Adam Vogel, a colleague of mine in Australia, he's developed a fantastic app, and I'll kind of show you a little clip of that in a minute, where the person meets with a therapist online over the phone once a week, and then they go and use the app to do practice at home, and it addresses lots of different areas important for speech. And again, Adam has published 2 studies on small groups of people. The first one was on RSACs, and has found some improvement in intelligibility and also naturalness of speech. The person is producing the speech. So it's kind of working on voice. It's asking the people to go up with the pitch. They go ah, and down ah, changing the loudness, and then actual speech and looking at, speaking at the right rate, tempo. Are you clear with your pronunciation? Okay, so very briefly, what we've been doing with this sort of Clear Speech Together, which is a very different approach. So with the app, you're very independent. You work in your own time. You practice. You have to be motivated yourself to go and sit, but it is very flexible. You can work it around your daily schedule, and you are being followed by the therapist. What we did with Clear Speech Together, this was developed during COVID, and Sue came to me and said, our members are reporting their communication is going down the hill because they don't have any opportunity to talk anymore. Can we do something about it? And so we devised a group treatment, but it's also individual treatment, so it's a combination which hasn't been done before. So the people see a therapist for 4 times over a period of 2 weeks by themselves, where the therapist tries to give them all the right strategies about how to support their speech, and then they go into a 4-week period where they practice with other members with ATAXIA, and the therapist is not present in those groups. So basically it's a kind of peer support, and people try and encourage each other, share their experiences, and work through a manual that we have devised that has exercises that go along with them. And we did the study with 9 people. That was the original pilot study, and since then ATAXIA UK has been fantastic in raising money and actually providing that to their members who can't access therapy otherwise. And we've had 6 groups that have run so far, and the feedback from the people has been very similar to what I've just going to report to you now in terms of positive changes to their speech, as well as sort of overall confidence and psychosocial well-being. So this is our intelligibility improvements. So I had, again, 2 assessments before we started therapy. Number 3 is immediately after therapy. Number 4 is 8 weeks later. So we try to get a little bit of a long-term view on it. And what you can see is that for a lot of people, their intelligibility went up. For some reason, most of them were worse on the second assessment, but that was just something in that group. But intelligibility went up. It went down again in the 8 weeks later when there wasn't that kind of intensive daily practice, but most people again managed to stay above their pre-therapy levels, but for some it dropped. And interestingly, the ones who did drop quite low were the ones sort of lockdown started again, and they didn't get any further opportunities to practice, and so they kind of lost a bit of their gain again. And just a quote that said, people are saying they don't get asked to repeat quite as much as they did before, and this person really said it really changed his life. So that was a lovely quote to get back. We did look at confidence, because I said it's important not just to look at what the speech outcomes are. And again, we can see here, sorry, the numbers that disappeared. We had 1 before therapy, that's the first line, and then the other one is immediately after, and you can see pretty much everybody increased there, and then either in the 8 weeks later stayed at that level, increased a little bit more, except for 2 people who dropped again. They were the ones who lost all their social contacts again during lockdown. And again, people were kind of saying, my confidence has improved, I'm speaking more now, I'm speaking longer words, and I don't avoid joining in conversations again. So that's exactly what we're looking for as an outcome for therapy. Okay. And finally, this is a sort of actual measure of communication participation, which looks at how much does your ATAXIA interfere with talking in different situations. So it's kind of got, talking with people you know, as well as the ones you don't know, having to speak for longer, etc. And the graph, again, the green bar is what happened before therapy, the blue one immediately after, and the red one 8 weeks later. And so, again, you can see for everybody, their participation improved after therapy, and there's only 1 person where it dropped again, and the others maintained it or increased further. So, all of a sudden, all together, we've had some really positive outcomes of the research. And how am I doing with time, Sue? Okay, perfect. Obviously, my therapy was a bit different to the others because we had that group element. And so you're kind of saying, does it have to be a group? Because groups can be difficult to organize by therapists, and also they can be a bit intimidating for people to take part, and you have to make sure that you get people that match with each other. So we wanted to see whether there was something that was actually beneficial specifically from the group setting. And what people kind of said, there was a lot of social benefits arising from the group, just actually meeting other people with ataxia. You're not the only one who has that problem. Sharing coping strategies, sharing frustrations, very important, and giving each other psychological support. And I can think, well, that's something you could get from attending a support group as well. So, do we still need to do it as part of speech therapy? But additional comments kind of showed us that that is actually quite an important component, because what we did was that everybody got the opportunity to talk, because that's the way that the manual was set up, which that doesn't necessarily happen in a support group either. And what people also found is that, having that constructive criticism of and the feedback was saying, actually, you do sound really good, because some of the strategies we give people make them sound a little bit strange, having to speak slower all of a sudden, or changing something about your speech, but hearing from others that has made a difference, and not just from the therapist, but others who have got the same problem, they felt that was really, really beneficial. The other thing is that because they were trying at first in that very supportive environment of other people with the same problems, they kind of felt it gave them that confidence to then go out into the community and again use those strategies. Motivation to practice, but we did see them every day, so they met Monday to Friday. The therapist joined once during that week, checked that everybody was doing okay, kind of explained the exercises for the next week, but they had to be there every day, and we know from other studies that intensive practice is the way to go. It really lets you kind of internalize the strategies that we're trying to impart on people, but it is difficult when you're by yourself at home, whereas having to meet with others in the group and doing the practice together really helped that aspect. And the manual starts from saying single words to actually having like a little presentation, conversation with others, so it does help you practice in those real life situations. And the other thing that I didn't think was going to be very important, it was a necessity for me, but I've got good feedback on, was that each patient had to chair the session, because we needed someone to keep an eye on time, etc. And they actually felt that kind of helped them take some agency again and reestablish their roles of being able to guide others. So that was useful as well. So, as I said, generally very positive outcome. But we're not the only study that has found positive outcomes. So I think the big message to take away is that speech therapy can support people with progressive ataxia, and I think that's what the therapists are shying away, or have shied away from in the past. They didn't know whether it would work and whether it could spend the resources on it. But there's a very clear message that yes, it can, and everybody should go to the therapist and say, there is research now, you can help me, and we need to push for that. The effective therapies have basically worked on voice, on sort of clear speech, clear articulation, so that seems to be the way forward. Intensity is seemingly an important factor, and again, this is where the Clear Speech Together works well, because there's actually only 6 therapist sessions, but the patient gets 24 because they're working by themselves, and so that seems to be a good hybrid model. Any therapy you do needs to look at that you can transfer those clinic strategies to real life, so it needs to have the carers, the families involved, to be able to give people a space for practice if it's not within a group. But really, really important to consider as well is it's not a one-size-fits-all. So it needs to be tailored to the individual, and not everybody likes groups, not everybody likes apps, so we need to give people the opportunity to choose what kind of therapy approach they want. Just very briefly, a couple of other takeaway messages. So we've heard about voice banking already. So, at some point, in some ataxia, speech might get so bad that you need some artificial aids to help you speak, communicate. It's much better, much more acceptable if that is your own voice rather than some American male speaker speaking for you, and therefore voice banking is really, really important. And with AI, the technology develops better and better. So think about if you have a type of ataxia where it's likely to degrade a little bit more, think about voice banking. The other thing, as mentioned, is language problems. It might affect some people, so it's very important for the therapist to look at that as well, not just to focus on speech. And patients and carers aren't necessarily aware there is a language problem, but the clinicians needs to look at that. So if there's anything goes wrong with the conversation that's not just based on you not understanding the person, or you not be able to get your message across, get someone to look at that. And then I did mention swallowing problems. We use the same muscles for speaking as we use for swallowing, so there are likely linked together. It can result in serious health risks, and as we said, that there's a kind of social element to it as well. So please do talk to an SLT or a dietitian or the neurologist, if there are any issues with that, you start choking on drinks or food. And I think that is so thank you very much again to ATAXIA UK for sponsoring all my work so far, and I hope that's been informative for you. Do you want me to sit up here or go back?
So I think if we have questions for Anya now, if there is anybody who has any questions about the speech therapy, it has made a huge difference, I think, within ATAXIA UK to our members. It is very, very popular. We can only take 5 people per Zoom course, as it were. We have a waiting list of 60. So we definitely need to increase the resources, and we are doing a course every 3 months, and we've done that for the last 18 months. So we've already put quite a few people through it. And what's really interesting, and it reflects back to the peer support element that Anya was speaking about, is that many of the groups continue to meet after they finished their 4 weeks of intensive session, and they want to carry on seeing each other. So I don't know how easily it would be to transfer this to other countries, but that's my first question to Anya.
Yeah, sorry, I meant to say that. So I have set up a manual. There's a clinician manual and there is a patient manual, which kind of takes you through the group phase. It is open access, so anyone can have it. So if you want to email me, I can send it to you. Obviously, it's in English, but it's sort of very generic exercise that should be easily translatable. So there's initially there's a few games activities, but it shouldn't be too difficult to find the sort of resources based on the examples in your own language. So I'm very happy to share that with anyone.
So if any of you in other countries have somebody who is prepared to fly the flag for speech therapy, an active, committed speech therapist, I'm sure that Anya would be very happy to have a conversation with them about the work that she has done in helping us to introduce speech therapy to people who are able to access Zoom. There is another issue, of course, about digital exclusion, because if you can't get on the Zoom, then you can't participate in these sessions. But on the other hand, the work that Anya has done will have given speech therapists ammunition for them to be able to provide services to people face to face. Are there any questions? Yes, Marios?
Thanks very much, Anya. Brilliant work. I just wonder how much of it also is the group element, because I guess an analogy would be the physiotherapy that patients with ataxia receive. So once they're seeing the physio, sometimes with other individuals, they are very motivated, but then they're given a set of exercises to do alone, and it kind of never seems to materialize. So I think the group element must be an important part of this.
Yeah, that's exactly why I was looking into groups. So, Sue came and said, we need to get people together because there's a lockdown. But before that, I'd already thought about this, because the first trial I ran, which was the LSVT, you have the 4 sessions a week and you're supposed to practice every day as well. And if you don't do the practice, it doesn't work. And what I found is, it didn't work as well as I wanted it to, and I think people just didn't practice by themselves. So Adam's app works a bit like that because it's monitored and the therapist can see whether you practiced or not. And so there's that kind of extra push. But if you have a session a week with a therapist, which is your kind of standard UK offering, and then you say, well, go and do these exercises until I see you next week, it's very unlikely that people actually put that effort in. And that's why I thought if we're doing it in a group, you don't have to do that additional practice by yourself. You can if you want to, but you're all practicing together. And so we're kind of beating 2 flies with 1 clap. I don't know what the English idiom is for that. Sorry.
Is there anybody else that would like to ask Anya a question? Yes, Bart.
Hey, brilliant talk. I appreciate the whole holistic approach you're having. Did you ever consider putting in like a hierarchy of the group element? I know from other disciplines, people take a training in a group and then take alumni and put them in the next group to sort of pass the experience on and increase the speed where people are socializing and learning into the next level.
Yeah, we were thinking about that, and quite a few people finishing with the group actually offered to say, because what we did with the group is that we kind of had some volunteers sitting as well. So far it's been ATAXIA UK staff who've been sitting in as volunteers, but that's the kind of next stage, is actually taking the alumni of the previous programs and feeding them, because they have a lot to offer to the rest of the group, and just in terms of encouragement and keeping them going and imparting their wisdom that they've learned already. So yes, thank you. That's definitely something we're considering.
Thank you much.
Okay, well, thank you very much to Anya for making her way here from Scotland. And we very much thank you for the work that you're doing. I know it's making a big impact. So can we thank Anya in the usual way? And now our next speaker is Mariana Cosman. I'm up here without my glasses. I'm looking at a label over there, and the stuff in front of me is dancing. So, Mariana, I think probably I'm going to ask you to say your own surname. So, Mariana actually has, I think, established all about aquatics.
Yes,
And
it's our
that's
therapy.
part of her work, but she's here as a lecturer from the Metropolitan College in Thessaloniki.
Yes, correct. So thank you once again. Thanks the organizing committee. Thanks the president of Hellenic Association of ATAXIA, Mr. Karadzias, and Euro ATAXIA. It's my pleasure to be here and to present you a refreshing session, because the temperature is really high right now. So I'll try to transfer you in a refreshed environment. My main area of research and of therapeutic management is in aquatic environment. I'm a physiotherapist, and I'm teaching physio at the Metropolitan University, and our aquatherapy department is all about aquatics and is based at Thessaloniki, North Greece. So our main concern always, when we are in contact with a patient, no matter the age, is why to suggest or why to enter in the water. What aquatic environment has to give a plus to the daily life activity. So we always want to have a better blood circulation all over the body. And what up to now research has shown, and also the physicians, what suggest is always to have brain wet, and when wet brains, also patients are happy. So we very carefully follow the guidelines of who suggest also aquatic therapy for patients with ataxia. And this is how we organize our aquatic environment. What we need is a pool with specific temperature, and we will see why the temperature is really important for patients with ataxia. And as you can see me in the water, having a very young patient and trying to make his life easier in the everyday activities. So as you can see, we can apply aquatic therapy in supine position, also using aids in the water, so that we can strengthen the body, we can apply the head and spinal cord alignment, and also to relax the muscle tone. So what we are using for advantage for the patient is the physical properties of water. And quickly I will go through the properties, because we have a fight in the water. When we enter in the water, the body has to face not only the body's own deformities, but also we need to face gravity. But gravity, when we walk out of the water, is much heavier than when we function in the water. So what we want to stabilize is to stabilize the influence of gravity and the influence of buoyancy, so it can flow in the water and have either supine or a really nice walking in the water without the effect of metacenter. So I'm using in advantage the buoyancy, the relative density, the hydrostatic pressure, the viscosity. And the viscosity that I'm using is that suggesting the patient to walk in the middle of the pool the hydrodynamic resistance, so I can gain strength, muscle strengthening, also the thermodynamics and the refraction. So the research in the water is very limited, so there is a big research gap, but the neurophysiologist Sato gave us a nice journal on 2012 and suggests that also the patient with ataxia should enter in the water, because water immersion, just the simple immersion in the body, what has to apply on the cardiovascular system, musculoskeletal system, respiratory system, and of course neurological system. And we will see forward how this functions. So what we have to bear in mind is the somatosensory input. When I enter into the water, what's happening? My heart rate goes lower, but the stroke volume amplifies. So I have to work more in the water. And also, I have to work more because my functional residual capacity gets lower. That's why I want to work in the water, walk, either just moving my limbs in the water against the resistance, because I will also strengthen my respiratory muscles. So, how the somatosensory system affects? As I said before, little is known because there is a research gap. So when I enter into the water, I have to think three facts: the tactile, the pressure, and the thermal. So when I have to correct the tactile sensory, I have to think what kind of method I will apply in the body. So my hands on the body, so I have to choose one of the evidence-based methods in water. Also, the pressure that I will apply in the skin, the surface, is through the hydrostatic pressure, and also the thermal, the temperature of the water, will also affect my body temperature. So why is important? Because I have also to regulate the somatosensory system of the patient in the water as well. I don't want to over-exceed the temperature of the body when the patient will enter in the water in a very hot environment, talking about 32 to 34 degrees of the water. So how we work? First day comes when a patient comes in our department. What we need to do is to formulate the patient classification. So I have to formulate my assessment for aquatic environment, and we do not apply something different from the classical physiotherapy. So we follow the International Classification Function Assessment Framework. As you can see, patient is always in the middle. So we need to do the first assessment, to apply the intervention, the reassessment, and then to see the results. So in this time, when we have done the first monitoring in the pool, then we move to the laboratory. We are very happy and glad because we collaborate with the Department of Sports and Physical Education, and especially the Laboratory of Biomechanics, and we collaborate with Dr. Vassilios Panoutsakopulos, and he's the one who applies the gait analysis, the posture analysis, and the EMG, the electromyographic monitoring of the patient before we start the aquatherapy session, in the middle, and at the end. So just a quick example to see what we can monitor and how we can use the results of a simple gait analysis in order to improve not only the movement in the water, but the motion outside of the water of our everyday activity. So what we can see on the left side is how the 2 feet are grounding in the surface of the dynamometer. Red line is the left foot, and blue line is the right foot. Quickly to explain is what we see is the moment and how long the heel strike goes on from the moment from the first touch of the foot. And also what we can also monitor and assess is not only on the forward and backward movement, and also we can monitor and assess the mediolateral movement. Also, what we can see is on posture tests is how much loading between left side of our body and right side of the body, because the loads between the left and the right side also affects the stabilization and the posture. In combination with EMG, we can also realize that how the hip strategy and the ankle strategy changes during the instability and the imbalance that we can see in the loads between the right foot and the left foot. Also, another test that we apply at the laboratory is the quiet stance test, and we want to see how the center of pressure between the left and the right foot moves around or gathers in the center, so that we can see with eyes open and no vision at all how much it's the time when the center of pressure displacement, how long stays stable between the left and the right side. Also, another test is the sit to stand test, in order to monitor the activation between the extensors of the hip and the flexors of the hip. So what we measure here and what we realize is the lumbar paradox. This means that in order for us in everyday life to stand up from the chair, we need to activate the extensors of the hip. But this time, a patient with ataxia activates the flexors the same time with the extensor of the hip. So in our therapeutic management, in the multidisciplinary team, patient is in the center, and we are around the patient in order to make the life easier and walk easily and stand easily, speak easily, and to have a quality of life. So in the aquatic environment, what we have the target is how to manage the muscle tone with spasticity, with contractures, with the painful muscle spasm. We also focus in the balance, the static balance improvement and dynamic. Also, gait is a big issue for us in the water, relating the head and trunk alignment and the lower limbs. Another issue that we need to also program in the water is the cardiomyopathy, because as the previous speakers already mentioned, is the fatigue. So when we work in a session in a pool, we don't spend more than 40 minutes at the beginning in order to make good adaptations for the aerobic capacity. Also, the musculoskeletal deformities is another is a big issue for us. We want to eliminate scoliosis, the poor head control, the poor sitting. We want to have muscles more flexible. We have to work a lot in the muscle elongation. We have to eliminate the limited range of motion and the hollow foot. So working in the pool, as you can see me here, working in supine position, trying to make good alignment of head and trunk, also to strengthen the core muscles. And the big question for us is what to apply in the water. When we're talking about aquatherapy, it's not the session of just go to the pool and swim, because this is the direction that we always hear when the patient comes to us. He's telling us that they suggest me to swim, but swimming skill is something that we need to build with aquatherapy. So IATF, the International Aquatic Therapy Faculty, suggests the evidence-based methods such as Badra gathering method, water-specific method, aqua cycle. All of these methods are hands-on methods therapy, and we apply the methods in one-to-one session. You can see here that I'm handling the body from peripheral anatomical points, And what we want to gain is the alignment, the strengthening of the trunk, also the lower limb strengthening in order to re-educate the rotational of the trunk and also the freedom of the upper arms and also providing a support in fine motor skills. The other method is the Badura gas ring method. We apply this method in bigger patients because we want to give the correct alignment, the correct strengthening of the limbs, but the patient needs to be autonomous and ready to hear me and also to execute the task. The other method is clinical IG, originates from Japan, and as you can see, I do really work in the stance improvement and also the improvement of the respiratory system. And finally, what we do really work is the gait training, really important for the patient. And I would like to close my speech with a short video. Thank you very much.
Thank you very much, Mariana. I've been involved with ATAXIA for the last 16 years. I have never heard anything about the use of aquatics before, so a truly unique presentation. So thank you very, very much. I think that the residents of Thessaloniki with ATAXIA must be really grateful to be living in this area. So, are there any questions from anybody? So my first question is to say that I know that there aren't that many people active in speech therapy, but Anya has her colleague Adam Vogel in Australia. Are there any other people doing research on aquatics in relation to the ataxias?
I
think it's...
Okay, thank you. There is a big gap in the research relating the improvements using aquatic modalities. So what I wanted to say, I wanted to make an open call for Euro-ataxia or Hellenic ataxia to start the research because while I was writing my speech today, I also make a quick research on the PubMed especially, but there is no specific research. And there is a big variety of methods that we can apply only if we are educated and certified for the ataxia patient.
Right, so there is a real gap and we need to be looking to see how we can fill it. Yes, Shana?
I was going to ask, in the meantime, while we're doing the research, is there a way to get out the exercises or things we can give to our members and say, if you can get into a pool with somebody who can assist you, do these exercises and it'll help them in some way? Or is it we have to wait for a therapist to come and help us do that?
So what we follow as aquatherapists, we also follow the official guidelines. And the guidelines, what they suggest is work with the patient in the water until before the peak of fatigue arouse. Mm-hmm. So we monitor the patients. Sometimes we do wear polar in the water so we can monitor the heart rate. And then we do very big breaks. So if we work 10 minutes in the water, and a specific example is, for example, gait exercise in the water or Badragas method. So we will minimum work 10 minutes and then we will have a brave break until the patient will tell us, I'm ready. A lot of patients want to come in the water because they want to feel free. They want to feel that I can walk, I can swim, I can be in supine position, I can blow bubbles in the water, and afterwards I can have my respiratory system much lighter and also speak easier.
So are there exercises that you would be able to write down that, or tell people who are used to being physios in the water as aquatic therapists, is there something you can pass on now, or have we got to wait for more research?
So the reason I say that, Marion, is because we're promised a lot of things in the ataxia community. And no offense to our neurologists, they'll say, let's have hope, a cure is coming. 5 years, 10 years, we go back and they tell us, don't worry, there's hope, let's believe that we want solutions now. So if there is a way we could get these exercises to the members in the meantime, that is so powerful. And the work you're doing, it's really great. And I want to exploit that a little bit and try and get that to as many people as we can.
Of course, we can write down the guidelines for aquatic therapy session, especially for a patient with ataxia. And what I have to suggest is always to monitor the patient. until the big research, and what I mean big research, I want a big sample of the patients to measure, to assess. So it's not a matter of a long time measuring the patients. We do have the prescription, we do have the methods, the therapeutic methods, and also we do have the functional training for the patients. So,
Okay, so can we have a lesson outside then? Are we ready
yes,
to go?
yes, because it's really hot here.
Are there any other questions? So thank you very much, Mariana, for bringing us your knowledge, and we hope that you have started something here that can roll out across Europe and wider. So thank you very much indeed.
Alors, in France, they had worked with a great team of neurokinetic, Iris Marilou, who actually has built a set of exercises designed explicitly for ataxia patients. So maybe that would be a good idea for us to fund, let's say, Mariana's work and establish, let's say, we will build on the French, let's say, model in order to expand it into the water. Okay, so I think that everyone needs a break, 30 minutes break, the cafe and refreshments and the main bar in nearby the pool. Okay, and then we will kick off. 30 minutes break.